Good afternoon and welcome everyone to the California Black Health Network's Health for Life series on breast health. I'm Rhonda Smith, the Executive Director of the California Black Health Network, and we thank you all for attending the session today. So the Health for Life series is a new initiative at the California Black Health Network that really aims to improve the health literacy of Black Californians so that we can really cultivate a more proactive and empowered community of individuals who are truly proactive about their health and well-being and take ownership in doing so. So our session today is entitled Women, Wisdom, and Warriors. We know that women have different levels of risk for breast cancer, and we know that breast cancer is simply just not one disease. So despite the advances in breast cancer treatment and breast cancer care, breast cancer still remains the second leading cause of cancer death in women in the US. And while Black women are diagnosed at nearly the same rate as white women, we unfortunately are about 40% more likely to die from it. So it's important for us to learn who gets breast cancer, why they get it, what type of breast cancer they get, and what we can do to reduce women's risk of getting the disease and definitely dying from it, especially Black women. So, which is basically what we'll be talking about today, and the importance of focusing on mammography screening and early detection, and also participating in clinical trials. And so we'll be focusing more specifically on the WISDOM study, which is an acronym for Women Informed to Screen Depending on Measures of Risk. And so we want to stress the importance of being proactive about your breast health and your breast cancer screenings every year, especially for Black women, and to encourage more diverse participation in clinical trials and medical research. So we have a great lineup of Black women for us today to talk about this topic. We have a medical oncologist, we have a WISDOM study participant, we have a WISDOM study advocate and ambassador, and a couple of breast cancer survivors. But before we get into the discussion for today, just a couple of housekeeping rules. Please note that everyone will remain on mute throughout the duration of the session. The chat box will be open if you want to give a shout out to somebody you recognize or know who's on the call today or the webinar today. But if you have any questions, please place your questions in the Q&A box. And so before we introduce the first speaker, I want to take a couple of minutes just to give an overview about the California Black Health Network for the benefit of those who may not be familiar with us or it's the first time being on one of our sessions. So next slide, please. So our vision is to create a California where every African-American and Black immigrant has the opportunity to live a long, healthy life that's free from violence, racism, and health inequities. And we do that every day through our mission to ensure that all Black Californians, regardless of where they live, who they love, how much money they make, their housing situation, and so on, really has access to high quality, equitable primary and behavioral health care, and don't avoid unnecessarily succumbing to diseases. And so I'd like to move on and introduce our very first speaker. Next slide, please. And that is Ms. Ricki Fairley. She's quite an amazing person. She's a breast cancer survivor and CEO of Touch, the Black Breast Cancer Alliance. And so she's busy, don't know how she keeps up with everything in her life, but she is a co-founder, as I mentioned, of CEO Touch, the Black Breast Cancer Alliance, to address Black breast cancer as a unique and special disease state for Black women. She founded and serves as co-host for The Doctor Is In, a weekly live breast cancer advocacy web series on blackdoctor.org. She is a founding member of the Black Data Matters in partnership with breastcancer.org. Ricki works very hard and fiercely to encourage and elevate the importance of Black women participating in clinical trial research. And in January of this year, she started When We Trial movement to really change the game on Black women participating in clinical trials and to improve outcomes, and definitely change that statistic around the 40% difference in survival rate for Black women versus white women. I could go on and on about Ricki, but I think the one other thing that's important to note is that she has 2 daughters and 3 granddaughters that I know she loves immensely and really is the joy of her life. And so without further ado, I'll turn it over to Ricki to share her story about her work and why she's so passionate about this cause.
Thank you so much. Thank you so much, Rhonda. It's such a pleasure to be here. Good afternoon, everyone. And I hope you guys are all having a good day. I'm actually in New York at an event with some incredible Black women that I'm so impressed by, which I'll talk about in a little bit. But first, I'll tell you my story, and then I'll talk about kind of the state of Black breast cancer. But I'm a 10-year survivor of triple-negative breast cancer. I was diagnosed with stage 3A disease. I did a double mastectomy. I did 6 rounds of chemo that was standard of care at the time. I did 6 weeks of radiation, and my doctor said, okay, now you have no evidence of disease. Almost a year to the day of my diagnosis, my cancer came back on my chest wall. My doctor said, okay, Ricki, you are now metastatic. Get your affairs in order. I don't have anything else for you, and you probably have about 2 years. And I said, well, I can't really die right now. I have a daughter in Dartmouth, so me, you, and God, and some drugs or something, I have to work this out. And I learned that she had really only had 2 cases of triple-negative breast cancer, and both of the women died after 9 months. And so I went on Dr. Google, and I Googled around, and on the 3rd page of Google, after saying, you're going to die, you're going to die, you're going to die, I found the Triple-Negative Breast Cancer Foundation. I called them, and they found a doctor for me, and she was probably one of about 5 doctors in the country that were doing research on triple negative. So I went to her for a consult, and actually my doctor went with me because she wanted to learn. She was pretty young, and she put me on 2 drugs that at the time were experimental for TNBC, carboplatin and gemcitabine, and they are now standard of care for triple negative, but they were experimental at the time. I did a lot more chemo, and I'm still here 10 years later. So I know that God left me here, first of all, to get my daughter through college, which I was able to do. And then I was sitting at graduation with my family saying, okay, what's next, God? And I know that he left me here to do this work. So I'm a crazy advocate on fire to get this work done and to talk about breast cancer and to talk about Black breast cancer. And I kind of named it Black breast cancer about 2 years ago because of the crazy, crazy statistics. So I'm going to share some numbers, okay, with you that just are compelling numbers. So, and Rhonda kind of spoke to them a little earlier. So Black women have a 41% higher mortality rate than white women, despite having an even playing field on getting breast cancer. Black women like me who have had breast cancer, we have a 39% higher rate of recurrence than white women. Again, Black women like me, survivors, we have a 71% higher relative risk of death than white women. Black women under 30 are 38% more likely to be diagnosed with breast cancer and 2.6 times more likely to die of breast cancer versus white women. Black women under 35 get breast cancer at twice the rate, die at 3 times the rate of white women. So these statistics for 30-year-olds and 35-year-olds and under, that's well before you would get your first mammogram recommended for age 40, right? We're more likely to be diagnosed with aggressive disease, more advanced disease, and with what I had, triple negative breast cancer. And triple negative breast cancer, I'm gonna leave that for Dr. Sara to define it for you, but it's the most aggressive breast cancer. It has the highest mortality rate. It affects Black women at 3 times the rate, and we don't really know why. And we die from it at very young ages and we get diagnosed at late stages. It's a horrible disease, and really only until within a year ago do we have drugs that are specifically designed for triple negative. 1 just for early stage and 2 for metastatic, but that just happened in the last 2 years. And so we really haven't had a drug for our disease. So it's kind of been the luck of the draw, right? Black women tend to have dense breasts. What does that mean? People with dense breasts are 6 times more likely to develop breast cancer. And so it's really important to know what your breast density is. So I kind of we wrote a definition for what Black breast cancer is, and I'm going to read it to you. Black breast cancer is a constellation of exposures, experiences, and lack of science. That's so important for Black women diagnosed with breast cancer that causes Black women to face disproportionately worse breast cancer outcomes. So the key words there, clearly everybody wants to kind of blame it on the social determinants of health. We have access to care and transportation and living in food deserts and all those things, those social factors, but it's really because we don't have the science. And so I went digging into why is this happening? It's crazy, right? And so if you look at the clinical trials for the drugs that we currently have available as standard of care, guess what? They weren't tested on Black bodies. They were tested on white women. So hello, the drugs don't work for us. And if you look at what's happening right now with clinical trials, we only have 3% participation in the trials for the drugs that are currently being developed. So I was at ASCO a couple of weeks ago, a big cancer meeting in Chicago, and I was looking at all these posters of drug developments that's happening, and you'd see on the top of the chart, this trial has 200 women. How many are Black? 1. This trial has 1,000 women. How many are Black? 2. So it's happening in our face that they are not putting our bodies to test. So the drugs aren't working. I want that bottle to say, this drug is specifically for Black breast cancer, for Black women. And we have to make that happen. And the only way we're going to make that happen is by advancing the science. And so when you say the word clinical trial, it's a scary word. It sounds like a petri dish and it sounds like failure, right? So how do we get people to understand what that means? And I did a big research study about a year ago with 300 women with breast cancer, Black women with breast cancer. And what I learned was the voice of trust is, guess who? Us, a breastie. It's not a club that you want to be in, but once you're in the club, it's unconditional love and trust. And we all believe what everybody says, right? But I learned that our breasties were maybe sharing wrong information with other breasties because they didn't know. Oh, girl, don't do a clinical trial. You're going to get the sugar pill and die. Or you don't want to be a guinea pig, or you don't want to be an experiment. All those, earned medical mistrust myths were coming up from Henrietta Lacks and the syphilis study. But I learned that, we don't really know about it. And really a lot of the reasons why people aren't participating is because they're afraid, because of fear. And if you think about what fear is, think about when you're afraid of something, right? You're not going to jump off the bridge because you don't know how deep the water is. You're not going to open that door because you don't know what's on the other side. But when you educate people and explain to them how the science works and what it is, then all of a sudden the fear goes away. And I learned pretty quickly in our research that I could convince a breastie to go from a 1, no, I'll never do a trial, I'm scared to death, to 5, sign me up for a trial in 5 minutes. And how was that? With really simple information, just explaining what standard of care is, right? That you're going to get a drug that already exists on the market, right? And then you may get that drug plus another new drug, or another new drug just by itself that could do better for you, right? So just explaining the science, and then saying stuff like, that Advil you took last for a headache a week ago, guess what? It was in a clinical trial. That antibiotic you gave your dog was in a clinical trial. Everything's in a clinical trial. The science is all around us. Every time you turn on I'm working on my iPad right now. It's science. Science is all around us. And it's really just the same science. The other thing too is that in clinical trials, we have better outcomes. You're getting better care. You're getting more people watching over you. You're getting, more people, more scans, more information, more people, caring for you. And so, and a lot more attention around your disease. So it's really a great place to be. And we're seeing patients who are living on clinical trials longer because they're trying drugs that are new and could have better outcomes for us. And we're seeing that. And then lastly, we all are crazy. I have a purple cape and a gold crown, and I'm running around taking care of a lot of people all the time, like we do as Black women. But so do it for your daughter. If you don't want to do it for yourself because you're too busy taking care of everybody, do it for your daughter. I work for my granddaughters. I got 3 precious granddaughters, 1, 3, and almost 5. And I work for them because I don't want them to talk about breast cancer anymore. And we have to advance the science. And as Black women, we are badass women. Okay, we are badasses. We can move mountains when we want to. We get people elected. We make things happen in our communities. We're all, doing things in our community centers with our kids. And so we have to take this on because no one else is going to do it for us. Doctors are not asking us to participate in trials. They're not, and they aren't going to. So we have to take this on ourselves and advocate for ourselves and ask for the trial and say, when you're in that appointment, doctor, take your hand off the doorknob. I am not done talking to you yet. I want to consider a clinical trial as a treatment option. Tell me about it, and force those conversations with our doctors. We talk about health equity, and right now, guess what? There is no health equity. It's health inequity. We're not going to have health equity until every healthcare provider practices the golden rule. What your mother taught you when you were a kid, what you learned in church. Treat others as you want to be treated. And that's why I say to our patients, when a doctor gives you a treatment plan, say, hold on, wait a minute. Is that how you would treat your mom? Is that the treatment that you would expect if this were you? Is that how you would treat your daughter or somebody important to you that you love? And that's the care we deserve. But we have to demand it. We have to ask for it. We have to get it. And we have to do this work, you guys. We have to. So if there's an opportunity for a clinical trial, take it. I've actually been in 3 trials this year, not for drugs, but for behavior. They're measuring the stress in my life. They measured the chemicals in my house and on my body. I did a test last week, about a couple weeks ago, with testing my DNA to see if it's different. And now there is a growing body of research. It's happening all around us. That guess what? A Black breast cancer cell looks different from a white breast cancer cell. They are different cells. It is a different disease. And the drugs that we have are for the white breast cancer cells, not the Black ones. So we have to get these drugs. We have to do this work. We have to get over the fear and get rid of it. And there is no sugar pill in breast cancer research. You're going to get treatment. You're going to get even better treatment than you would taking a regular drug. You're going to get more attention. And we're going to develop a new standard of care for Black women. That's my goal. We need our own standard of care. We need our own drugs. We need something that's going to really make a difference in our families. So, what can we do? What can you guys do to help us out? You can, first of all, know her story, know your groups. I'm going to pull my screen down.
I'm not quite sure what happened to Ricki. So Ricki, can you hear me? Or am I the only one who's frozen?
Yep, we can hear you.
Okay, great. Ricki's frozen. I'm not quite sure what happened, but there's always something happening with technology. So yeah, Ricki, if you can hear us, can you say something? You're frozen on my end. And if you're not connected to us anymore, we can say thank you and move on to our next speaker. But I think Ricki definitely shared some valuable information today. And hopefully, I think one of the things that's important to know, and maybe Dr. Horton can speak to this, is about dense breast and mammography screenings and what people should know, and Black women in particular should know about dense breast and as it relates to mammography screening. So I'd like to introduce Dr. Sara Horton. Dr. Horton is the Executive Director of Access and Diversity for the Quantum Leap Healthcare Collaborative. She's a practicing board certified medical oncologist for over 20 years. She's the affiliate associate professor of medicine at Howard University Cancer Center and a medical oncologist for the transdisciplinary breast clinic team. She's also the past division chief of hematology and oncology and director of clinical trials at Howard University Hospital, and the past FDA medical review officer in the division of breast, GYN, and GU cancers. And on a personal note, she is the mother of one. Dr. Sara, I'll turn it over to you to tell us more about the WISDOM study and what women need to know about participation.
Okay, thank you, Rhonda. It's always so hard speaking after Ricki because she is such a fireball and a source of great information, but it's also great because she's already kind of set the stage to discuss, for me, an amazing clinical trial, but also to kind of give that education about the importance of being involved in studies. But first, I'd like to thank you for involving me today in the California Black Health Network kind of panel. It's an important week. It's Black Family Cancer Awareness Week. And as it's already been discussed, just about across all cancer, there's a disparity in outcomes in terms of Black patients not living as long as other patients for a lot of different reasons. And as Ricki alluded to, there have been a lot of studies looking at what we call the social determinants of health, meaning things like having access to care, having the money to have insurance, things that are more social economic, not our biological reasons. But we also know that there's probably a difference, probably a little lesser level, but there's a difference in some of the biology in Black breast cancer as a whole. And the important part of clinical trials these days is trying to increase that body of information on Black patients so that we can further identify what will work in a specific patient, if they're Black, if they're white. But we know that we know a lot of information about white patients who have had who have had cancer, but we are really lacking in the data about Black patients who have had cancer. And so today, I'm wearing my hat as the Executive Director of Access and Diversity for Quantum Leap, which is one of the kind of housing and helps to facilitate the Wisdom Study, which I'll talk about at length, along with University of California, San Francisco. So the Wisdom Study, which is, the Wisdom is an acronym for Women Informed to Screen Depending on Measures of Risk. And so we know that right now, when a woman is screened for breast cancer, meaning she is sent to get a mammogram, our guidelines pretty much across the board recommend starting at 40, some 50, but most people 40, and yearly mammograms. And we know that not everybody needs to be screened the same. Some women have indicators that they may develop breast cancer at a higher risk than others and may need to be screened more often or with different modalities. And some may be less likely to develop breast cancer and may not need all that screening, exposure to radiation. But the challenge is to find out how we can identify, if there is a way that we can identify how we can stratify women for screening for breast cancer. Because for us, we know that for 30, oh, I'm sorry, I see there that my slides are not shared. Okay. Are you all seeing my slides now?
Oh, yep.
Okay, all right,
Yes,
sorry
thank
about that. Okay. And is it on the full screen?
Yes, it's
Okay.
still, it's on the title slide though, so I don't know if you want to advance. to it.
Okay, got it. Sorry about that. I'm so many Zoom webinars and I still can't just go through my slides all the time. So, so what we do at the Wisdom Study is to try to develop an algorithm that will better help identify women who are at a higher risk of breast cancer and to give a more personalized recommendation for screening. So basically, we're trying to revolutionize breast cancer screening to improve women's health. Let's see. So during the presentation, I'll discuss a little bit about breast cancer and screening. We'll go into the background of the Wisdom Study, and then I'll talk about how you can get involved in the Wisdom Study. So just some background information on breast cancer. We've probably all heard these numbers that in the US, about 280,000 women diagnosed with breast cancer. So that's a risk of 1 in 8 women developing breast cancer in their lifetime. So if you've got a group of 10 friends or 8 friends, 1 woman will likely be diagnosed with breast cancer. So in terms of mortality or death from breast cancer, yearly in the US, about 42,000 women in 2021 died from breast cancer. So we're getting better. The mortality is going down. We're getting better at treating breast cancer. But one of the things that we're finding is that the improvement in survival and mortality is not being seen in Black women at the rate that we're seeing it in other women. And that's a concern. So when you look at this slide, it talks a little bit about, again, our mortality rate, which is the death from breast cancer. And it also talks about the second slide about triple negative breast cancer, which is one of the most aggressive cancers and which unfortunately is found at a higher incidence among Black women, which may be one of the reasons why there is a higher mortality rate. So the first slide just is a bar graph, and it's looking at the differences in mortality by race and ethnicity, as well as incidence. So if you look, so for non-Hispanic white women, they have the highest incidence. That means that more breast cancers are picked up. They have the, when you look at how many women were diagnosed with breast cancer, the highest incidence is within white women. And that could be for a lot of reasons, maybe more screening, maybe it just occurs more in the population. But you look at the mortality, and it is, though their incidence is higher than Black women have the highest mortality out of all different race and ethnicity groups. And so that's where we're kind of focusing on why is that? What can we do to help identify it? We're always looking at better treatments for women with breast cancer, but we're also trying to prevent this from happening. And so what we're trying to do in the Wisdom study is identify markers for risk for developing breast cancer so that those women can be screened earlier, because ultimately, the best way to cure a cancer, if it's going to happen, is to catch it early. And if you can catch it early, even if it's triple negative, or if it's a which is the most aggressive to the least aggressive, no matter what it looks like in terms of under the microscope, if you catch it early and remove it, your chances of survival are much higher. And so that's the importance of screening with mammography. So this slide is a slide for triple negative breast cancer. Again, we just show that for the Black population, it's a higher incidence in all ages to other populations, and also that, you know, younger women have a higher incidence of breast cancer compared to white women and just about all other races. So that's another reason to wonder, is there something in the biology? Because, you know, getting to a doctor or, you know, being able to have insurance won't determine whether you get cancer at 40 or 50. Okay, so there must be something genetic or at a mutation level that may be affecting women more in the Black population than others. So when we talk about breast cancer, and again, the importance of mammography, we know that breast cancer is not a single disease. We know that there's all kinds of breast cancers. There's fast-growing breast cancers, which if you look at this tumor D, this is one where it may be at a level of not being able to be detected at all. And then very quickly over time, it may get to the metastatic level. That is a fast-growing cancer cell. But then you have some breast cancer cells that just are really slow growing, and they may be there slowly for years and years. And then maybe you can detect it on mammograms when they're in their 80s. And we know that if you have a more aggressive tumor, it spreads faster, it's more lethal, and it's important to identify those at a small level, like all, but a early level with mammography if possible. And these are the type of tumors that may show up in women who have had yearly mammograms. Last year I had a mammogram, it was totally negative. Now I have a mammogram and it's already spread to my lymph nodes after 1 year. Well, that already tells us that's an aggressive cancer. And maybe we can identify women who may have these type of aggressive cancers earlier by looking at genetics and other things and intervening maybe with the use of MRI added or MRI at 6 months so that we can catch these type earlier and prevent ending up with metastatic disease. And also we may be able to identify women who have these slower growing ones that show us that maybe every 2 years mammograms are good, because these are the type that wouldn't cause a problem for many, many years. So I know it can get a little complicated, but I hope it makes sense as to why it's important to have more information in terms of identifying the best way to screen for breast cancer. So what do we know about breast cancer screening? Right now, we know that the guidelines vary in terms of what is recommended in terms of when you start mammograms for women and how often. It goes from starting at 40 and every year to starting at 50 every other year and everything in between. We know that mammogram rates have drastically reduced because of COVID. You know, people were afraid to go out. And it made sense, but what that means is our expectation is we're probably going to get an increase in breast cancers over the next few years. And so what we want to do now as women start to getting back into screening and have a comfort level of going out and getting their mammograms is that we want to improve that number of women who are dying from breast cancer despite having a mammogram. So this is a slide, and I'll just very quickly go over. This is just 3 different bodies of institutions that develop guidelines that we look at for screening mammography. So the American College of Radiology recommends starting at 40 years with an annual mammogram. The United States Preventative Services Task Force recommends starting at 50 years and with a biennial, so every 2 years, mammogram up until the age of 74. Well, we know that, just like the last slide showed, that there's an increase, there's a higher incidence of Black women who develop breast cancer between age 40 and 50. So many people had a problem with this. It would be nice to have a better way of identifying those Black women who were at a higher risk so that we can more personally recommend screening. But luckily, most insurance carriers will cover mammograms at 40 if your doctor puts in for it and explains why they feel it's necessary. And the American Cancer Society recommends starting at 45 years with yearly up until 55, and then every 2 years, 55 and over. So one of the things that we want to do is make improvements in all the things that we use in terms of determining screening. And so we want to take into consideration all the advances that have been made, especially in genetics, as Ricki was alluding to, advances in risk assessment. We've used outdated models to determine women who are a higher risk of breast cancer. And more importantly, these models come from data that was gathered in clinical trials that were done years ago, which were almost 100% white women. And so a lot of the risk assessment tools that are used may not apply to women of color or women who weren't involved in the studies that this data was taken from. And also, you know, there are legal changes in the patient's rights. So we need to really make sure that we know that patients know about their family history and things that can increase their risk for cancers. And then also the advances in technology, which sometimes results in higher costs. But, you know, if it's something that's effective, we need to find a way that everybody has access to it. So what is the solution? So what we're trying to do is improve our screening algorithm instead, again, of using those old outdated studies to tell everybody that they should get screened a certain way, that studies that didn't involve people who looked like you. The Wisdom study is putting together a way of looking at integrating your risk assessment. So determining your risk assessment based on genetics, based on breast density, which wasn't used in the past, which we know Black women tend to have a higher breast density in general, not everybody, but it's something that needs to be incorporated. And then also all of the prevention that we know that can be incorporated in terms of, looking at family history, and prevention can be anything from increased screening to, if your risk is high enough, taking a therapy that helps to decrease your risk. We want to test a strategy where everyone is not screened the same, because we know that doesn't work, because we know that there's an increased mortality in African-American women using this way of screening. We want to improve the identification of women who have those aggressive tumors that show up between the mammograms. And we want to allow women to join regardless of where they get their care, meaning, I think Ricki was alluding to the fact that a lot of clinical trials are done at university or academic centers, may not be provided where you get your care, and I'll talk more about it, but the Wisdom Study is a study that you as an individual sign up for. Everything is done virtually or electronically, meaning you sign up for it on the computer or your phone, mobile app. Everything is conveyed through that type of technology. You'll get a call from a person once you join and register, but you don't have to go somewhere that may be inconvenient, may not be in your neighborhood, may not be something your doctor knows about, but you can do this on your own to join this study. And the goal for the study, which started in 2016, is to screen 100,000 women. And at this point, we're at about 48,000 women. And we'll talk a little bit about the number of those women who are African-American, as well as all kinds of women who are underrepresented on studies, Black, Brown. And we're doing better than most studies, but not good enough. And we have increased over the years, but there's a continued push, because this is a great study. It's easy, it's free, it allows all of the patients to get genetic testing and data that you otherwise wouldn't get. And it allows you, even if you don't want to go the route that the study recommends, you can decide, you know what, I still want to be in the study. I don't necessarily want to receive the screening recommendations, but I will be in an observation arm where you still can follow me and gather my information, so that that information can still be used to inform researchers about the different tumors and how they affect the development of cancer, of breast cancer. So again, the Wisdom Study is for women aged 40 to 74 who have never had breast cancer. And when you enroll in the Wisdom Study, you can decide on whether you want to be randomized for personalized screening or annual screening. And so the annual screening is what we do now. Yearly screening, that's what we call the control arm. You're still in the study. You get a yearly questionnaire that you fill out where it informs the researchers about any changes that may increase your risk for breast cancer. Your risk assessment is done every year, and we analyze the mammogram report. Personalized screening is if you opt or you're randomized to get personalized screening, that is when there is a combination of three things. There is genetic testing, which means that, and I'll go into more details, there are certain genes that we know increase your risk for breast cancer. Some are very familiar to people, the BRCA or BRCA genes that have the highest increased risk for breast cancer. But now we know that there are a group of what we call moderate risk genes, which don't increase as much as some of the others like BRCA, but it does affect your risk and should be incorporated into determining your risk. And we test for those, as well as what's called SNPs, which are changes in the DNA that we're finding are related to small changes, an increase, and some to decrease in breast cancer risk. And all of these are being incorporated into determining the recommendation for how often you should get your breast cancer, along with breast density, and as well as the family history that most women have been giving already in terms of determining risk. And for the genetic testing, it's a saliva test, but you're mailed a kit. You just kind of spit in the cup and send it in, and that's it. And you get your genetic report. And all of this information, should you decide to receive the personalized screening, goes to you to take to your doctor. So let's see, study questions about personalized screening. So safety, is it just as good at avoiding high-risk cancers? So that's what we're asking. That's what we're looking at as we follow women who are undergoing this testing. We have a control arm of women who haven't done the personalized screening, and then we have the women who have, and we're going to find out, are we catching cancers earlier, and are ultimately women living longer because of that? And we need to have women of color involved so that we can answer these questions for all women. Will it reduce biopsies and false positives, which is another kind of, I say side effect, but it's not a side effect. It just goes along with screening. Sometimes you find things on the mammogram and it's biopsied and it's not cancer. And that, even though it's a relief, it puts you through a whole process of anxiety and wondering, and that we want to get better at identifying things that are really high risk for cancer. Prevention, will it encourage prevention in high-risk women? So will, having this and the reminders and having a personalized study resonate with women to be more diligent in getting your screening? I know there are times, even for me, and I'm an oncologist, where I look up, it's been 2 years and I haven't had my mammogram. So we just want this to be, front of mind. And acceptance, is it accepted by women? Is this something that the participants feel comfortable in? Do they think that they're, doing good for themselves and others? And so that's why the education part is really important for us. And then ultimately, the most important question is it better? Is it better than what we're doing now, which is what we want? There is a personalized, the two arms we have are the control group and the personalized screening group. So the personalized screening group, I explained, is the group that goes through the genetic testing and looking at the breast density and comes up ultimately with a recommendation. And so we look at risk factors, mammography with breast density. Most mammograms do have some kind of comment about breast density. We're finding out more and more now that breast density is increased, a higher density is increased risk of developing cancers just because they're harder to detect. Is there a need for a better modality with mammograms like MRI? There's a health questionnaire with questions about family history, previous biopsies, all the other questions that we routinely have always asked, but along with race and ethnicity. And then, the novel part of this is the genomic profiling, where we looked at the 9 gene panel that includes the 9 most common high-risk genes for breast cancer, as well as the SNPs. I talked about the smaller changes that we're seeing that may increase or decrease your risk in breast cancer. And we get that from a saliva collection. Once we get all of this, screening recommendations are made based on the risk, and you'll get the risk score. Intermediate, you wouldn't change anything. High risk, there are recommendations for more screening, and lower risk, you may have recommendations for less screening. So mammograms every 2 years could be less if you're a lower risk. Annual mammograms, if it's just, medium risk, no change. Annual mammograms plus MRI if there's a concern about density or increased risk. And there may be, if you're in your 40s, if you're at a lower risk, there may be a recommendation that you can start at 50 as opposed to doing yearly screening at 40. And if someone is identified through the genomic profiling to have one of the high risk genes. There is a breast consultation that is done with a genetic counselor to discuss genetic counseling and potentially risk prevention measures. So that is, if that happens, if you have a high risk recommendation, you're not left to just figure out what to do. We continue to follow you, make sure you get in contact with the people that you need in your area to make sure you get the appropriate screening. And so I'm not sure how well you can see this, but this is just a picture of what women receive. This is the breast health decision tool, and it's called your risk snapshot. You basically log on. It's a very easy portal where you can just click on, your risk, and it'll show you, it'll have all your information, your age, and then it'll talk about the polygenic risk score, which I'll talk about, which is the score that comes from all the genetic testing, along with the wisdom study score, and then your screening recommendations that are written out. And then they also look at risk changing modifications that you can take to help decrease your risk of breast cancer, looking at alcohol intake, your BMI, your body mass index, exercise, if you do it or not, and medications that you take. So in terms of the genetic testing, again, I talked about the hereditary cancer genes, the ones like BRCA, which may highly increase your risk for breast cancer. And we look for BRCA1, 2, and these are some of the others that may not be as common to a layperson, but they are genes that are known to increase your risk, which are considered high risk genes at different levels. And that makes up a very small portion. So we wanted to make sure you understood that these hereditary cancers only make up 5 to 10% of all breast cancers. So it's a small portion. It's important to know because there is an increased risk of breast cancer that can range from 30% to 80%. So that's why it's important for you to know specifically what your risk, because not all BRCA positive patients have the same risk. It's very individualized. And then I want to just kind of pound that home that there's not one flavor that fits all, even amongst racial groups. And Ricki's right, it's very important. We know there is something about breast cancer in Black women or people that's resulting in Black women, us having a lower survival. I don't think that all Black women should be treated the same. I know that over the years, 20 years or so, I've treated a lot of Black women with the drugs that we have now, and they've done well. So these drugs do work well in some women, but some they don't. And we need to know who those women are, just like in Ashkenazi Jewish women. We knew that there was, in that group of women, a lot were developing breast cancer. That's how they found the BRCA gene. Once they found the BRCA gene, they knew to look for it. And not all Jewish women are treated the same, but the ones who have BRCA, just like a Black woman who has BRCA is treated with a specific drug for that. And so we want to know if there's something among the Black population, a gene that's at a higher incidence that we can target, so that if we find that gene in the population anywhere, that we know what to use for it. And in this case, we would know how to screen based on if it increases your risk for breast cancer. So the other genes we look for have a little less increase in your breast cancer incidence, but altogether, these genes are used to come up with a polygenic risk score. And so one of the things that we've learned from the years of the wisdom study so far is that we've had over 20,000 women who received genetic testing in the personalized arm. We know that about 2.5% have a pathogenic mutation, a mutation that we can identify as increasing the risk. We know that 67%, or 2/3 of the mutation carriers, do not have a first-degree family history, first-degree family relative history of cancer. So that's important to know, that just because you don't have a strong family history, and there can be lots of reasons why, you know, because you had a small family. Nowadays, people are having one kid, two kid, and it may just not show up. So you might be adopted. There might have been, you know, different reasons. But when you look, we have all of these genes now, and we know that just because you don't have a family history doesn't mean that you don't need to be tested for that gene. And so that's one of the things that we like about Wisdom, is that women are receiving genetic testing that they may not otherwise qualify for, just because we don't have the data to support, because we haven't looked at this in other populations before. So the polygenic risk scores, which is called PRS, which comes from looking at the sporadic, the SNPs, over 300 that will be looked at gene changes, are used to develop a score to tell us if a woman may be at higher or lower risk. And I will tell you that when you look at all these SNPs, these genetic changes that are not the really high risk ones that we know, but we know it affects breast cancer. When we look at all of those that we have looked at in the women, most of them fall in the middle. It's a bell curve where it wouldn't change anything in terms of what we would do for their risk. But we do know that we have identified a pattern for women, for some women, that correlates with a lower risk. And we have some that we know, as we followed, correlate with higher risk, potentially up to, you know, someone who has a BRCA. And it's important to know, you know, those SNPs and what their effect is on your chance of developing breast cancer. Now, when we look at the Wisdom study so far, again, that was started in 2016, and we've got about close to 50,000 women, it was important to look at representation. And before 2019, there was about 1.7% Black women in the study, even smaller. And it was important at that point for the study to, the people involved with the study to improve that. So they applied for and were awarded an NCI grant to help increase the diversity of the study, because despite best efforts, sometimes it's hard to get people to participate. And so over the years, the numbers have increased, mainly because of thoughtful, targeted involvement of sites where, and in sites, even though you can, any woman can enroll anywhere, there are hubs where the study is just, you'll have a center that really promotes it. And so they started looking at some of the southern places like LSU and Alabama and University of Chicago, and specifically targeted sites where there are a number of underrepresented populations, and increased the numbers. And now we're at about 4.2, which is nowhere near where we want to be, with the US population of Blacks being 13%, but improving. And this is one of the things that we do to help inform the community, is to talk about the study and let people know it's there. Okay. So this is just background. Ricki talked a lot about this, and it's so true, is that if you look at the red, and this is clinical participants in clinical trials. The red are European, okay? The majority of patients on just about all clinical trials, and I saw this at the FDA time and time again, are not people of color, okay? So if you look at the African, we're right about here, okay? And we have, you know, the Asian population is second in terms of the number of the higher numbers of participants, but we really need to improve our enrollment of non-white people onto studies. And so this is a schematic of the wisdom trial across the country. So there are wisdom participants in every state at this point. The hubs, again, LSU, we've got University of Chicago. The study started in California, so we have a lot of really high enrolling sites there, but the goal is to kind of increase these numbers everywhere. Now, how to participate? As I mentioned before, this is mostly done online. So thewisdomstudy.org, you just go to the site and start following. Super intuitive and simple. You use your smartphone, your computer. There's no cost to participate. You don't have to have insurance. You can, there are things that are billed to the insurance if you have it. If not, the study covers it in terms of, your mammograms and all. If you're not insured, we help connect people to places in their region to get mammograms. Right now, we follow women for at least 5 years, but as we get more data, we're going to be actually asking to follow longer with annual surveys, just so we can continue to follow to see what happened to women with this screening. One of the things we want to try to emphasize now is that everybody can participate in this study, and everybody can help encourage other people to participate in this study. Super simple. Knowing that all you have to do is go to wisdomstudy.org. You can talk to people in your community. If you're interested in this study and you want someone from the Wisdom Study to talk to your church group or your organization, you can just contact us through this email, wisdomcommunity@ucsf.edu. If you forget everything, you can always go to University of California, San Francisco, UCSF, their website, and kind of just put in Wisdom Study. There is a toolkit, a communications toolkit, if you on your own you want to talk about the Wisdom Study, and where you can distribute flyers. You can put an article in your newsletter. These are just ways that you can spread the word if you feel comfortable and you feel that this is an important study. So my last slide is, if you have any questions, please contact us at wisdomcommunity@ucsf.edu, and it's thewisdomstudy.org.
So thank you very much, Dr. Horton. That was amazing information. And also, the reason why it's important, well, the Wisdom Study, first of all, is important. Taking more of a personalized approach to mammography screening and breast health, as opposed to a one-size-fits-all approach. It's also important for, I think, to your point, for Black women to really know more about their risk factors, right? Their family history, all the things that are important, an important part of the Wisdom Study. But before we go on to the next person, I did want to ask a couple of questions, if you don't mind. And so, Ricki mentioned this, when we talk about dense breast or think about dense breast and mammography screenings. And we know that there's a dense breast law that exists in, I think it's about 8 states, maybe more states by now. So can you talk about the importance of knowing whether or not you have dense breast, and then how that relates to the reliability of mammography screenings and the outcomes?
Yes, and you're right. There are laws now, thankfully, that are being passed, and hopefully more and more states will pass them, that will require the mammographer to actually put a density score in the reading of your mammogram. So it's not routinely done now, which is frustrating because we're finding out how important it is. And so I'm not sure, like you said, I thought the last number I heard was in the double digits, like 12, but
maybe by now, yeah.
It's increasing, and people should ask. I mean, what I always say is, whenever you get your mammogram, even when it came to things like 3D, before 3D mammography was offered, just ask the place. Once they keep hearing it, that people are asking for it, it's more likely that it's something that will be adopted. And if you want to go a step further, if your state doesn't require it, talking to the politicians that are your local ones or your state to say that you're interested in it. But for the wisdom study, we do ask for mammograms to see if there is a density reading. If there's not, a score is given for the highest density because you don't want to miss out on someone. There are times when if an institution where you have your mammogram doesn't give density readings, you can always ask. Again, you may not get that, but the more you ask, the more they're going to hear it and know that it is important to you. So what that means, the density, as it's kind of intuitive, if you have a more dense breast, when you look at the breast on the mammogram, it looks more white and it may hide a mass if it's small. And so right now, there is a recommendation if you are a certain density level to add an MRI to your mammogram. And so that is, an actionable thing that can be done to help detect.
Right. So one more question and then we'll move on. So last month, we were fortunate enough to have 2 descendants of the Henrietta Lacks family, 2 of her grandchildren, Jerry and David. And, they talked a lot about their grandmother's story, of course, but also kind of the fact that, things like that don't happen anymore, and also how the family participates in that. So I know one of the reasons why we're talking about this today is to try to mitigate some of the fear that people may have about medical research and clinical trials and the comfortability in participating in that. But I think one of the slides that you showed really provided evidence for the reason why, because a lot of us take drugs. I mean, even myself, I take drugs for hypertension, but we don't always know or really experience that they are as efficacious for us as they are and maybe the folks who participate in those clinical trials. So I think the same thing applies here. But if you were to give, I guess, one message to the women in the audience, especially Black women who may feel that way about participating in clinical trials, you talk about how that really can benefit us, in addition to some of the things I mentioned.
Okay, yeah, so important because of our history, and I think what has happened is that as a population, we've missed out on opportunities for the scientific world to know about our diseases. So I use the BRCA example a lot, but if you don't participate, we'll never know if there's something different about our bodies, our cells. We're at a level of scientific expertise where we can look at a cell and we can look at molecules and find different proteins. And we know that we call those drivers. We know that those proteins, what they do in the cells, we know how to target it with drugs. But if you don't know that you have that marker on your cell, you won't know if that drug is meant for you.
Right.
And this is just helpful for not only us, but for the generations coming after us, so that they don't all have to be in clinical trials too. I mean, to find out what's good for them. So it's once you're involved in a study and something is studied and it's found to be efficacious, it becomes standard of care. But without a study,
we won't know. Yeah. And so I think what you were referring to just a few seconds ago was around precision medicine, right? So even with the advances in medical treatment, right, we're still seeing the disparity in terms of outcomes when it comes to breast cancer diagnosis. So, so again, all the more reason for us to participate and have that conversation with our healthcare providers about participation, and knowing that that is an option for us, especially when we talk about triple negative breast cancer, and if it's a late stage diagnosis, that is an important conversation to have. So thank you, Dr. Sara. I know you're going to hang around for a little bit in case there's some questions a little bit later, but if we could move on to Lakita. I'm sorry, actually, Kathy, my bad. So the next person that we're going to hear their story is Kathy Levy. Kathy comes to us from University of Alabama in Montgomery. She has more than 30 years of experience in healthcare and community relations. She is employed by the Go2 Foundation for Lung Cancer and the University of Alabama's O'Neill Comprehensive Cancer Center as the Community Outreach Coordinator. She also has extensive community outreach, engagement, and awareness knowledge to navigate patients through healthcare issues and also educate patients on health disparities related to cancer. In her spare time, she enjoys shopping, reading, traveling, and spending time with her family. So thank you, Kathy, for being here, and looking forward to hearing your story.
Thank you. So hi, everyone. I will just speak with you briefly on participating in the wisdom study, and also about encouraging others to participate in myths and barriers. So let's just start with myths and barriers in clinical trials, and especially in the Black rural communities in the Black Belt of Alabama. So back in 1932, and we're going back to the Tuskegee issues that they had with African Americans. So, you know, the study back then was on syphilis, and it was just a study, it was unethical. So I'm sure all of you have heard the story, and I won't go into details. So with that syphilis study back then in 1932, it's not easy encouraging African Americans to overcome the myths and barriers about the clinical trials. There are so many questions from some, and there's just an immediate no from others. They always refer back to Tuskegee. So being an advocate in the community has its challenges when trying to get people to agree to participate in clinical trials. But we will continue educating on the importance of the study in our communities and encouraging everyone to participate. So at this point in time, we need to kind of put Tuskegee behind us and continue to try and build trust within these communities. So barriers to screening in rural Alabama consist of, the number one issue is transportation. Not all of the rural hospitals in our rural communities are able to perform mammograms. So other barriers are fear of pain, anxiety, and we're forever saying that you're gonna die, and you gotta die with something. And really and truly, they will tell me that I don't want to know if I have cancer, so just let me die without knowing. They just don't want to know. And also a lack of trust from people that come into the communities that they are not aware of, or maybe know nothing about them, and the healthcare providers in our communities. No insurance, or underinsured, and they just don't have an interest, lack of knowledge, and misconception. So why is it important to join the wisdom study? So for the past 2 years, I have been encouraging women to join the study, to receive that personalized breast and mammography report to reduce breast cancer disparities. And for me, this was just so amazing. I share my experience with everyone, and I always tell them what I've learned from the speakers, the clinicians, and also the health experts on the monthly calls about screening, education, and about breast cancer. So after I completed my personalized breast and mammography questionnaire, I mailed in my saliva sample, just really simple. And when my report came back to me, I wasn't at as a higher risk as I initially thought that I was. So now I'm only required to get my mammogram every 2 years instead of every year. So the wisdom study is important to me because both of my maternal grandparents, my grandmother and grandfather, had breast cancer. So before the study, like I said, I thought I was at a higher risk. And after talking with my healthcare provider, I was encouraged to join the study. Far too many people in our communities are losing their lives to breast cancer at an early age in the Black Belt of Alabama. So now I talk with women. I also talk with the people in the local churches, the pastors, community leaders, or to anyone that will just listen to me about the importance of clinical trials and the importance of getting screened. It's important to me to take all measures, to take whatever it takes to talk to people to get them screened. I want them to get screened. So when you talk about clinical trials are safe and they are effective. And they also provide or help prevent and cure diseases and save lives. And that's the important piece of it. It's about saving lives. So if you're on the call, and to everyone that's on this call today, for once in your life, follow me and join the wisdom study and learn more about breast health and saving lives. Thank you.
So thank you very much, Kathy, for sharing your story and your reasons why you participate in the wisdom study. And I really appreciate your enthusiasm and to encourage other women in the community and educate them about the importance of this and how it can decrease disparities and outcomes for Black women in particular. Just a couple of things. So I think one of the things that has happened as a result of the Henrietta Lacks family being more involved in medical research and making sure that there are protections for patients is something called informed consent. Is that something that you can address and share with everybody and what that is?
So back with the syphilis study, that was one of the things that they didn't do was get an informed consent form signed. So working with the University of Alabama in Birmingham, that's one of the things that we make sure that we, if there is some type of clinical trial, anything dealing with research or something like that, we have to get a consent form signed by the participants and also provide them a copy of that informed consent signed so that they can have it to refer back to it later. So it's very important to get that done prior to talking with them or to get them to join. So that's what we do at the University of Alabama in Birmingham.
Right, and it generally is a standard practice that happens when someone enrolls in a clinical trial, and that means that the person who opts in basically understands everything there is to know, and there's transparency in that clinical trial. Is that correct? Is that generally what
that is true?
Okay.
Yes.
Great. So there's more protections in place than there were
Right.
what you mentioned when the Tuskegee experiment happened, and definitely in the case of Henrietta Lacks and other, medical research stories that we've heard about that weren't so favorable for the Black community. So thank you for sharing that.
Sure.
And so still, if you have any questions, you can put them in the chat. I know we run a little bit over, but this is really great information. And we have one last person that we want to hear a story from, and that is Wakita Berkeley. And she'll tell us, her story around the story that she had to tell and information that she had to share with her family and what that was like. And so Wakita is a 45-year-old woman of faith, a wife, a mother who she now lives in Texas, was in California. She was diagnosed with stage 0 DCIS in 2018. And now she really kind of takes that experience to help answer questions and work collaboratively with others to create solutions around breast health and breast education. So she treasures spending time with her husband and her three children, who is the source of inspiration and purpose in her life. And I guess one thing that she does outside of spending time with her family is she likes to relax with an elegant cup of steaming hot tea. And I guess you may do that outside on your patio or somewhere if it's not too hot in Texas, now that you're not in California anymore. So I'll turn it over to Wakita to share her story and why she's part of the Wisdom Study and is an ambassador and advocate for it. Thank you, Wakita.
Thank you so much, Rhonda. And I just want to say what an honor it is to be part of such a distinguished panel of women this afternoon. I'm appreciative and I'm so grateful for this opportunity to share with you in honor of National Black Family Cancer Awareness Week. I just want to say there's so much information that has been shared on this call. You all have just been blessed with so much information to help you as you move forward and think about your own personal health care, in particular, your breast health. As Rhonda stated in the introduction, I was diagnosed with stage 0 DCIS back in the fall of 2018. And I just want you to just imagine a little bit with me for a few moments. If you were a wife, mother of 3, 2 girls who were aged 10 and 12 at the time, and a young son who was the age of 4, receiving a breast cancer diagnosis over the phone while the children were in school, trying to comprehend that diagnosis along with her husband's support. And did I mention that he was on another continent at the time that I received this information? Trying to maintain composure as she processes, or as I process, researches, and explains what it all means to my 3 children. Well, unfortunately for me, I don't have to imagine, this was actually my reality. To say that it was a lot to navigate would definitely be an understatement. And as been explained on this call already, the gamut as far as the breast cancer diagnosis ranges from where I started with stage 0 DCIS all the way to metastatic. And we are women who are living, who have been on this journey, who are thriving, and who are out here being proactive and trying to encourage as many as we can to get that early screening, to be a part of a clinical study such as Wisdom, so that we can learn more about breast cancer, save more lives, and provide so much more hope to all women. My journey actually began after a visit to my primary care physician. She found a small lump in my left breast prior to leaving for summer vacation and suggested that when I returned, I follow up by having a mammogram done. So as instructed, I followed up, had the mammogram done in the doctor's office. My primary care physician had noted where she felt the lump. However, after the mammogram, it did not show a lump at all. So while I was there, I was also given an ultrasound, which revealed that there was a small mass. And from there, it was suggested that I schedule a biopsy. A few days later, had the biopsy, got the results back from that, which confirmed that I did have stage 0 DCIS. That information was shared to me over the phone right before I needed to go pick up my kindergartner from school that day. There was no one at home with me, so I was trying to process this information, collect myself so that I could then pick up my children, try to resume the day as much as normal, as I inside was freaking out and also trying to communicate what I had just learned with my husband and my mother, both of which were not in the state where I was located. My suggested treatment for stage 0 DCIS was lumpectomy, which is a surgery to remove the cancer tissue from the breast, radiation, and then a medication by the name of tamoxifen that I would take for about 5 years after that. But as you know, everything in life does not always flow in a straight line. And so instead of following that very direct advice, I had a lumpectomy and 2 re-excisions. So in other words, my breast surgeon performed surgery 3 times in an effort to achieve clear margins and was unable to do so. As a result, it was recommended that I have a mastectomy of my left breast, which is removing all of the breast tissue there. After doing some research on it, I decided that for me, I wanted to have a double mastectomy, and that's what I did. And since then, I have been very blessed to recover from that and resume my life as it was prior to this diagnosis. However, it will forever be changed as a result of receiving that initial news of you have breast cancer and delving into what all that means. But today, I just want to share that with you to give you a little bit of background, because I want to focus a couple of minutes on how that type of news impacts one's family, in particular, a family that has 2 pre-adolescent girls and a boy who is much younger. My husband and I wanted to be very transparent with our children. We had a circle of friends, family, church family, sorority, fraternity, loving arms of village around us, and we knew that we would be sharing that information with them. But we also wanted our children to know directly from us first what was going on. So what we decided to do was, at the dinner table, we sat down, had a meal, and afterwards, if you can imagine, at this table, it's a rectangular table. My husband and I are sitting on one side. On the opposite side in front of us are our 3 children, and they tend to sit young, middle child, youngest in the center, oldest on the other end. So the 3 of them are facing us. And my husband begins the conversation, letting them know, there's something we need to share with you all. And in my mind, everything just kind of became very surreal. And I remember hearing him say, "Mommy has breast cancer." And it was like I was frozen, and the kids just, the reactions were immediate on their faces. My 2 daughters started crying. My son was looking confused from one sister to the other, like he's 4. He didn't quite comprehend what was going on. So I woke up out of my state of shock and trying to explain this to my children. And I just said to them, as the social worker and the oncologist and the breast surgeon had shared with me in the office before, that Mommy is going to be okay. The doctor is going to perform a surgery. I'm going to have this treatment called radiation and some medication after that, and everything is going to be okay. So my husband and I, we sat there for a while with the children. We answered their questions. We let them know that we would keep them informed along the way. And if at any time they had questions, they could ask us, and we would be more than happy to share, to comfort them, and to be there for them. And I know that telling children is not a choice that a lot of people choose to make, but I do want those of you out there who may be going through this, or who know someone who is, or in the future you may come across this, just know that a lot of times our children, they need to have the opportunity to understand and process, and they most importantly need to know that we're there to support them. And for me, having 2 young girls who were, as I stated, going through puberty, we had conversations about breasts and their changing bodies and buying bras, and they would always kind of snicker and look away whenever I used the word breast. But it was so interesting how once I received this diagnosis, which forever changed my life and also changed theirs, breasts became a regular part of our conversation, to the point where it was no longer something they snickered about. It was something, that they had a new understanding of. And for me as a mother, while I don't, I guess, how can I put this? Being diagnosed with breast cancer was something that no one wants to be diagnosed with. But from that, and then going through this particular journey, I was able to help my children understand the importance of breast health and breast care. They know about my body and things that are going on with me, which is something that, as I went through this journey, learned different things about women in my family that I did not know and may not have known had I not been diagnosed with breast cancer. So it's an opportunity to share knowledge with the younger generation as well. So if you'd like to know more about my conversation with my children, there's actually a blog post that I've written, and I can share that in the chat, and you'll see a picture of my family, and it kind of goes into more detail about that conversation at the dinner table. But I just am so thankful and grateful for the support of my parents, my church family, sorority, family and friends, and blessed to have a successful recovery. And I would just want to express to those of you who are listening to please, please, please be proactive about your breast health. the wisdom study is an excellent opportunity to be able to get the screening that you need to determine how much screening you actually need. Unfortunately, I'm not able to participate as a study participant, but I am an advocate for it because I see the benefit in being able to understand exactly what's needed, something that's personalized to help you as a woman understand how often do I need to have mammograms? What type of screening do I need to get? So there's a lot of value in participating in this study. And I hope that after today's conversation, you will be inspired to ask more questions and to sign up for it. So thank you so much for listening and for your time.
So thank you, Wakita. And I think for you and others probably like you, it's like the conversation that you really don't want to have with your family. And so a quick question for you. Do you think that if you had known about the wisdom study before your diagnosis, that you would have ended up in the same situation, or your situation would have been different with your diagnosis? Just curious.
Yeah. I think that if I had known about the wisdom study, it would have helped me. Now, I will say, and I've heard this brought up several times this afternoon about dense breast tissue. And I did have very dense breast tissue. So does my mother. And I will also say that because of that, I also had benign cysts in my breast. So I was not a stranger to having mammograms done. So when I was diagnosed, it was very shocking to me because in the past it was, oh, it's nothing, these are benign. But I do think that if I had access or knew about the wisdom study prior to being diagnosed, it would have gone a long way in helping me get that personalized screening that could have, helped me along the way. So definitely.
Thank you for that. And so I wanted to make sure that we got everybody's questions answered who did have a question, but I only see one real question in the chat, and that's mainly for Ricki, but I think if I maybe attempted to answer it. So knowing her story is really, I think, a lot about what the wisdom study is all about, is really knowing, your risk factors, your family history, and then figuring out what is right for you when it comes to managing your breast health and getting your mammogram screenings. And so I'd like to bring everybody else back on to give them an opportunity to make some closing remarks and leave some words of wisdom, no pun intended, on with the audience that's still here and listening today. And thank you all for staying on a little bit longer. So let's start with you, Dr. Horton. Okay. What would you like to leave with the audience today?
First, I'd like to thank Kathy and Wakita for sharing their stories. I think that, hearing personal stories really resonate with people when they're listening, knowing that this can happen to anyone. So thank you. So I just would like to leave with the message that the most important thing that you can do for yourself and your family, as you'll hear, is to be an advocate for yourself. Education is available. Knowing that you don't have to rely on someone else, a doctor, to tell you about what's best for your body is important. Knowing your information, especially in this era of precision medicine, knowing your genetics is so important. And to ask that question, get comfortable with saying, doctor, do I need genetic testing? You have to just say that because sometimes it's not top of the mind. And being able to be comfortable with saying some of the things that sound kind of, unfamiliar to you is going to be helpful. So that was it.
Great, thank you. And I think you were also going to mention something about iSpy.
Oh, iSpy, yes. So iSpy is another study that is under Quantum Leap Healthcare, but this study is in particular, it's what's called a treatment clinical trial. So this is a study for women who have stage 2 or 3 breast cancer and who would receive what we call neoadjuvant or chemotherapy before surgery. And so what we know, and then trying to say this very quickly, is in the past, We gave chemotherapy after the cancer was removed in the hopes that it will help some women prevent the cancer from coming back. Once cancer is removed and you give chemotherapy to it, you can't really tell if it's helping it or if it's not. So now in cases where you have at least a stage 2 cancer, while it's still in the body, the chemotherapy is given, you can see if it responds, and it can help tailor the type of treatment that will be best for you. Because if you're getting a treatment and your cancer is not budging, it doesn't make sense to keep giving that treatment. So we also know that I-SPY has been around for a while, and the goal is to treat with what we call novel, new therapies that are more targeted, have less side effects, and are more specific by looking at the genetics of your cancer for you. And so the I-SPY trial is open now. This is something, if you know someone who has breast cancer, and the beauty of the I-SPY cancer is not only does it more quickly test, it has 10 arms of many different treatments. Instead of having one study that you're on that tests one drug and you have to wait for it to find years to find out if it's effective. It's called an adaptive platform study, one of the first of its kind, where it keeps the patients in the studies. If something's working, they keep you on it. If you don't need certain type, if the whole cancer goes away with the first treatment, then you can go straight to surgery, as opposed to receiving more and more treatment that really may not be of any benefit to you. And so what we're finding out is that not only is getting to a point where there's no cancer before surgery can help improve survival, we're also becoming able to tailor certain drugs to certain people. So it's the right treatment at the right time for the right person.
Great. Okay, thank you very much. And then
Okay.
Kathy, what words of wisdom would you like to share with everybody?
Words of wisdom for everyone.
Aside from what you already dropped today earlier, yes.
So, oh, wow. It's simple, sweet, and short. Just know your body. Don't be afraid to try new things or to try things that are presented to you, as long as it's not going to harm your body. And I guess the last thing is, we can't direct the wind, but we can adjust the sails. So just be proactive in your health, know your body, and enjoy life, and take care of your body.
Okay, thank you. And then Wakita.
Wow, Kathy just put it so plain and so simple and beautiful. I echo what she just stated, and I would just encourage everyone to just be proactive about your health. I know with COVID having taken place, a lot of people have put off checking in with their doctors, following up on appointments. Please make sure that you're checking in. Even if you feel like something is a little bit off, ask questions, bring it up. As stated before, advocate on your own behalf. And if you can, or you're having problems doing that, there is support. There are agencies, there are organizations out there that can support you. I know there's Sisters Network, Inc. That is particularly catered toward Black women available. There's Komen, Tiger Lily Foundation. There are many out there that can provide you with the support and even financial resources in some cases to help. So just make use of the support system you have around you would be my biggest advice, and be very proactive when it comes to your health.
Right, and so thank you for emphasizing that, because if you recall, I started out in the beginning of this talking about the Health4Life initiative and how it's our initiative to really create a more and cultivate a more empowered community here in California, and hopefully eventually across the country, of our community really taking action and being proactive about our health and wellness on all dimensions and aspects of our health and well-being. And I think that will definitely have an impact on closing the gap in disparities and improving outcomes and life expectancy for folks here and across the country too. And so I want to thank you all for taking the time to be here today. You're all amazing, and I'm glad to be connected to you and know you and have you as part of my circle. I want to also thank the California Life Sciences for their support of the event today. UCSF and Dr. Esseman, I saw you, well, not saw you, but I know that you're here. So thank you for being here and all the work that you do, and for conceiving the wisdom study and making sure that it is a very inclusive study. I want to thank my friend Ria Blakey at the FDA and the Center of Excellence there for coming up with National Family Cancer Awareness Week so that we can really elevate the level of visibility and the importance of getting annual screenings and really knowing what works for you. And then just before we leave, I wanted to share a few reminders. Unfortunately, the font here isn't clear, but just a couple of upcoming events for us at California Black Health Network. On June 28th, we are slated to have a session on Black music and movement, the power to heal. So we are doing that in partnership with AARP in recognition of Brain Health Awareness Month and also Black Music Heritage Month. And then on July 14th, in recognition of Minority Health, Mental Health Awareness Month, we are doing a session on the impact of intergenerational trauma on the mental health and well-being of Black youth. So that's on July 14th at noon. Information about all these events will be on our website on the events page. There's a community, a partner community event that's coming up that's supported by UCSF, and it's Friends of Dr. Frank Stagger. So it's also an event that's in recognition of National Cancer Family Awareness Month or Week, and then also Men's Health Month. And that is on prostate cancer. That'll be a Zoom conference on June 25th. So there's more information, I believe, on the UCSF website. So you can go there to learn more information about that. So one other thing I want to mention before we say goodbye today, aside from thanking everybody for being here today, I apologize for the font color, but join us. You can connect with us on social media. We're on Facebook, LinkedIn, Twitter, and now Instagram. You can join the campaign for Black Health Equity. That is our major initiative to really address the gap and disparities here for the Black community in California and improve outcomes and life expectancy. So you can find out information about all of that on our website. So you can go to www.ca.blackhealthnetwork.org. So again, thank you all for being here today. It was great to have you, and thanks for staying on, those 58 people who are still here. So thank you and have a great rest of the week and happy Juneteenth. All right,
Ron,
take care.
can I add one little thing before? And I know I've talked enough already.
Sure.
Well, Akita brought up a really great segue into DCIS. And so, Akita, what happened to you happens to so many women with stage 0 breast cancer, all these different options that go from, just surgical removal to mastectomies. There are clinical trials now just because of what you went through, the same type of issue. So at UCSF, there are a couple of clinical trials now open specifically for DCS, looking at different levels of treatment to make sure that, and also looking at the risk of the woman with DCIS to have invasive cancer. So hopefully in the future, people will have a better recommendation.
Thank you so much for that. I'll look into that.
Okay. Thank you, everybody. Thanks, Dr. Sara. Thanks, Kathy. Thanks, Wakita. Thanks, everybody out in the audience. So have great weekend and happy Juneteenth, and have a safe and fun weekend.